We'll start, okay? Yes, this session actually welcome all in this new year. The first session actually in the 2nd of January. This 2021 will bring you all the success and or happiness. Happy New Year. To pass the exam, first of all, we have to know what is the exam. The parts of the exam are the exam constitute of the following: written exam, both one best answer, 6 stems with five choices to choose the best choice. It is one best answer from five. It is we are trying in the future to be one best of four, but this will be future, not for you. Unfortunately, we have problems. Are you hearing? We'll have problems. So problems, surgical problems have too long usually and 6 to 8 short structured problems. Uh, this will constitute actually 30% or more, 30 to 40% of the whole exam. And the OSCE will constitute 50%, and the rest is for the continuous assessment to constitute 100%. Next, Ahmed. Okay, Ahmed, next slide. Yes, the OSCE exam, usually it is 18 or more. We have agreed that on the Nilane Faculty of Medicine that the OSCE exam to be minimum of 15 stations, but we agreed upon 18. Or as you know, increases make the OSCE exam more fair. And so the best OSCE exam is that constitute of more than 30, that to make 32 or so stations. But they, for technical reason, for equipment rays, and this will have the video or the image or the X-ray or scan or a problem, and then have questions regarding the image or the video or the X-ray or CT scan or a case scenario. Actually, we'll have a patient that one of the case scenarios may be patient with excessive vomiting. He has this is urea and electrolytes. How are you going to replace his electrolyte deficit? Then you will go and answer in the answer sheet how you are going to replace the fluid and electrolyte of that patient. So this is the static stations mainly, and the static stations also is concerned by a limited objectives. OSCE exam is objective structured clinical examination. So any station has objectives, but the static stations, the objective of them is regarding the knowledge and criticism also. It is not assessing the skills actually. The other 10 to 8 interactive dynamic stations will be for, as you know, is divided in communication skills and unified it versus counting, consent taking, breaking bad news. All of these are communication skills. So you expect to have 2-3 stations of communication skills regarding history, consent taking, breaking bad news, discussing with the patient the options of treatment, what is next, or discussing with the patient what to do in the future about a certain disease. Okay, next. Then we come, and this constitute also of common surgical problem, examining common surgical problems like actually or areas, examining the neck, examining the hernia, examining a lump, examining lymphoma, sebaceous cyst, dermoid cyst, scleroid. It is a common abdomen of the patient, examining for or examining for a joint or examining a limb. So this examination skills is one important constituent of the dynamic institute. Most of the dynamic stations. If the dynamic station are 8, then you will expect 5 stations to be 10, then you are expecting to have 6 to 7 stations. There is another type of OSCE stations. In active OSCE stations is the procedures like inserting an NG tube, inserting a Foley catheter, suturing. Definitely it is in a simulated wound. It is not a true wound. Inserting an IV line actually in a simulator, inserting the catheter in a simulator, inserting an NG tube in simulator. Tolerate to have 100 or more patient, students inserting an NG tube in. Okay, so we'll use simulators. On OSCE, actually, the wisdom behind OSCE is that to decrease the number of patients used during exam and to increase the use of simulators, mannequins, actors, and so on and so forth. Okay, actually, the OSCE exam, all of the OSCE, actually 50% of the total marks of the final exam goes to the OSCE, and this will show you final year examination are a professional examinations. They are not a scientific examination. Okay, you get that? Any questions so far? Yes, thank you, Tawassul. Anybody else? Okay, if it's NFS is clear, then we'll move to the part we're going to concentrate in this session how to deal with the surgical exam. We'll start the written exam and we're starting with the long problems and the short problems. Actually, surgical problem, as the name implies, is to deal with a common surgical problem. One of the deal with rare cases of the surgery, but fortunately enough, the exam is dealing with the common, and this is fortunate. This is fair, because if we're going to bring you the 1% cases or 0.001% cases, then also you are not going to see them even maybe once or twice in your life. Them every day. This is about everyday practice. In the problems in general, you have Hindi. The examiner will give you a scenario. A scenario. We'll come to this. In this scenario, you have to consider the keywords, because these keywords have been written because to give you a clue about the possibilities, the differential diagnoses. And these keywords will guide you to know what further symptoms you look for. And when you do examination, what signs to look for and how to formulate the possibilities, the differential of management consisting of investigations, relative investigation, information adding investigations, and to start the treatment and to continue and to know what is a possible complication. The initial management, the final management, and the complication and prognosis, then this is a long problem. If it constitutes 2 or 3 of that, or 1 or 2, then this is a short problem. The difference between the long problem, the scope of the long problem is covering the whole problem in whole aspect. If you come to the next slide, we'll see that. Okay. Yes, this is one of the actually one of the long problems. 25 years of age, noticed to have an anterior neck swelling for 6 months. يبقى she's a young 25. If you can mark, put a mark about female 2010, anterior neck swelling, another 6 months. Same time started to have feeling of hotness all over her body. Over is not written here. Became ill-tempered and cannot tolerate hot weather, and noticed to have moderate loss of weight. Okay, in order to find a diagnosis. Yes, if we come to the first part, what are the keywords, Ahmed? Yes, Ahmed, what are the keywords?
Okay, firstly, the age or the gender and age. Then
yes, being a female, 25 years, yes, this is will indicate that we have to talk, we have to take care about the diseases. Okay, what else?
okay,
What else? Tawassul.
Okay.
Moderate loss of weight.
Yes, it will come from, yes, I agree with you. There is moderate loss of weight. What is next after 25? Anterior, being anterior, being for 6 months. It is not others.
Become
feeling of
duration of swelling.
Yes, duration 6 months. Excellent. It is not a short duration. Tani, what else? Yes.
The feeling of hotness.
All over her body. All over her body. Yes. And now Tani, ill-tempered. Okay. And cannot tolerate hot weather. Moderate, as rain. What are these keywords? What do you think this patient? Patient have an anterior neck swelling, 25 years, anterior neck swelling for the last 6 months. Well, at the same time she discovered the swelling, she discovered that she has feeling of hotness all over her body, ill-tempered, and cannot tolerate hot weather, moderate loss of weight. What are we talking about? What is the problem? It is a thyroid problem because it is an anterior neck swelling. مش كده? 6 months. So she's young, female, 25, feeling hotness, ill-tempered, and moderate loss of weight. What are we doing? Yes, you are. Regarding this is most likely thyroid with symptoms suggestive hypothyroid. What is the hyperthyroid? Thyrotoxicosis. You agree, مش كده? What is the common cause of thyrotoxicosis in a female of 25 years? You see, on the OSCE, in the last OSCE exam, we bring to you a photo of on Graves. Then thyroid problems are very common. You can see them in the written exam. Okay. What more symptoms to emphasize your diagnosis of Graves? What are they?
Tachycardia.
Palpitation, actually. مش كده? Palpitation. Yes.
Loss of weight despite good appetite.
Good appetite in spite weight loss in spite of good appetite. Okay. What else, Danny?
Tremor.
Yes, she used to drop things مش كده she drops things she cannot take
myopathy.
myopathy. Yeah, she may be having myopathy برضه still and she cannot comb her hair مش كده. These are the symptoms she used when she went to the kitchen. She used to drop the blades. Okay, she used to drop the cups. This because of tremors مش كده. She cannot comb her hair مش كده. She has some. The key thing to do in this question is to try the symptom or the question and why you are asking it. Even if he didn't ask you why you are asking, it will not take time. You ask about can she comb her hair? Ask because if she cannot comb, she will have myopathy. Can she drop these objects in the while working because she may have tremors? You get me? Okay. You get that because she will have a tachycardia. Okay, of thyrotoxicosis. Okay, you get that, and there is a change of the eyes. مش كده? Change of the eyes. The eyes may appear their place, and this is what. So this is you can take from this to have 4, 5 more about the menstrual cycle. مش كده? Okay.
Can we ask?
You can ask about orthopney.
Why
Thyrotoxicosis will affect. We do not. Did thyrotoxicosis affect the menstrual cycle?
Yes.
Yes.
In what form?
Yes.
Irregularity.
Type. Yes, اللي هي one of the signs or one of the symptoms of thyrotoxicosis. You have a lot of symptoms. Actually, the examiner can ask you about 5. He can enumerate 7 or more. You get it? So move to the next slide, Ahmed. Then we start with the symptoms. This typical lung problem. On her to be irritable with thin body build. She was not pale and her pulse was 120 per minute. And her neck show. Mention other 5 signs, physical signs you expect to find. البلس اداك ليه؟ انا اداك ان الثايرويد is diffusely large. يبقى تاني في شنو ناقص؟ what's next?
Eye sign.
Yes.
eye sign?
Eye signs. What? These are eye signs. What are the eye signs? Exophthalmos, protrusion of the eyeball. الثاني.
Can lid retraction.
Lid lag and lid retraction. This will lead to irritation of the muscles مش كده around the eyes, and this usually happen when you have overstimulation of the muscle because of thyrotoxicosis of excessive thyroid. طيب. What other signs you look
hand
for?
signs.
Yes.
Acrobacy.
طيب the hands will look what we feel the hands. What's the feel the hands will feel like?
Warm, moist hand.
Moist.
Warm and moist. مش كده? If they are cold and moist, then the baby have his feeling. Yes. his feet warm and moist. The tremors. Okay. تاني.
I look for pretibial myxedema.
Don't forget the thyroid. قال لك لارج لكن تلقى فيها شو ثاني؟ ثايروتوكسيكوز ممكن تلقى فيها شنو؟
Nausea or
With
osmosis.
pulsation.
ممكن تلقى فيها بروي مش كده ممكن تلقى فيها
Blue, yes.
Dilated veins.
فدي كلها don't forget about this. You can look for.
reflex.
Yes. Okay.
Pretibial myxedema.
So you can find more than usually the examiner will ask less than you will find. Next, please, Ahmed. The history بدينا ب history examination. بعد that you have to put a professional diagnosis. As you know, after any history and examination, you have to put a professional diagnosis. What is your professional diagnosis or clinical diagnosis? Because we have no history. What is the clinical diagnosis here?
Toxic diffuse goiter disease.
What we call it? Diffuse toxic goiter اللي هو Graves' disease. You have to write all this, please. Okay? You agree? You have to write all this.
Okay.
For some investigations, and found her hemoglobin to be 90% and urine was clear. عايزك تقول لي وديل ها. It can be would order for this patient. Mention to you the expected. Yes. What are you going to do? Patient عندها diffuse toxic goiter Graves' disease. What are you doing?
Thyroid function test.
Yes. What is بالراحة واحدة واحد. What is the importance of thyroid? Yeah. Mention the expected result.
بكون عنده low TSH and
high T3 and T4. Excellent, because low TSH then indicates that the patient have a thyroid or he has an inhibition feedback, as you know, negative feedback of the thyroxine of the T3 and T4 on the pituitary. Thyroid function.
Thoracic inlet chest X-ray.
Thyroid antibodies.
Thoracic inlet, because what makes us not interested?
No evidence
Because
of,
thoracic inlet,
pressure
no evidence
symptoms.
of
well, no
tension.
evidence. No
Well, the-
evidence of pressure symptoms. There is no pressure symptoms given. So it is not that important. The most thyroid function test and then group
Is the top scan?
to show that the whole thyroid is red, is function, is hyper function. Okay. What else? ممكن تحل؟
ممكن ultrasound.
Ultrasound, yes. Maybe this thyrotoxicosis is due to one focus. مش كده, although he give you a picture of, you know, the thyroid is diffusely enlarged, but still you may have a enormous the gross enlargement of the thyroid is universal and it is homogeneous. Okay. So you can put any two of these, thyroid function, thyroid scan, ultrasound, and you will give your justification why you choose these two investigations. Agree? Okay?
Okay.
Next, on the basis of the result, her doctor started her on irrigation عشان يديها medical treatment. Most likely, yes? Yes? Graves disease مش كده toxic toxic goiter it is
Beta
toxic
Beta block.
the toxic. What are the treatment? Yes, outline the treatment. Why and why you give it? Beta blocker.
Beta blocker to release the symptoms.
Adrenergic.
What else?
Anti-thyroid drug.
What anti-thyroid? What is the best?
BTU.
Carbimazole. Carbimazole. How are you going to use carbimazole? How much and how often?
We start 5 to 10.
Yes,
ECG.
5 to 10. How much? How often?
4 times per day.
Usually carbimazole is 8 hourly.
8 hourly.
Strict 8 hourly.
For 1.5 years.
8 hourly drug. Because of the you would follow the patient. مش كده? You talk about what are the problems of carbimazole.
Granulocytosis, infections.
If the patient come to you in the refer clinic after giving this patient, you give her carbimazole 10 milligram TDS 8 hourly, and then with Inderal, propranolol, beta blocker, 10 8 hourly or 10 BD or 20 BD or so, and the patient come to you to the refer clinic after 1 month, she's complaining of sore throat.
انا كان لازم من الاول لما انا اديتها الستارت تريتمنت اعمل بيز لاين وايد بي سي.
طيب and now
Stop the medication.
Yes, you have to check that there's a total. Maybe sore throat is a common symptom. By definition, it is not. It is an alarming symptom, but it is common. Maybe caused by anything rather than the complication. So first, you have to prove the patient having the complication of the drug. What are they? Sore throat is a common symptom, isn't it?
I will do
Yeah.
CBC
Yeah.
and
You do CBC. You have to. يبقى from the start when you give carbimazole you have to do total BBC, WBC, total white blood count before starting the carbimazole, and then you follow the patient with total white blood cells, and you educate the patient that if you feel sore throat or you feel any infection, please come back, okay, or tell your nearest doctor that you are taking carbimazole, okay. What other else problems of carbimazole?
Yes.
This is the major problem of carbimazole. Okay. Next.
Bone marrow depression.
Yes, my granulocytosis is the same. The doctors didn't cooperate. Okay. Anything else to say? Anything?
Teratogenic.
Yes.
ممكن hypothyroidism.
Yeah. Carbimazole. It is teratogenic if the patient want to get pregnant or so. She has to stop it. Is there any indication for surgery in a patient with primary thyrotoxicosis?
no.
Yeah.
Failure of medical treatment.
The breather symptoms.
Yes, usually they are not common in thyrotoxicosis, but failure of medical treatment, tani, what else? As your colleague said before today, the patient is get annoyed by the long use of carbimazole, and she gets its complications. Then you have to consider surgery. Another option before surgery, if the patient
radioiodine proven
yes,
that
radioactive iodine, but you cannot be. She's young, she's 25 years, so
I have to do pregnancy test first.
Yes, radioactive iodine is not advisable in a young girls of childbearing age. She is in the childbearing age, okay? You get that? So surgery may come to be as a second line of treatment. طيب what are the complication of subtotal actually هنا هو اداك actually if I were him I would do it but he do subtotal he's not going to yeah we are not arguing the management but the best management for a patient with cytotoxic goiter Graves' disease if you are going to do surgery is near total thyroidectomy rather than subtotal. Okay, what are the possible complications, post-operative complication of a patient with thyroidectomy? Let me, during an operation, during anesthesia, what are the complications early on? As you know, you can be
Thyroid storm.
Yes, thyrotoxic storm, and this is a nightmare of the anesthetist. It's not of the surgeon. What will happen?
Hypocalcemia.
Thyrotoxic storm, and his thyrotoxic is aggressive during manipulation of the thyroid. A lot of thyroxine the patient was not well controlled. مش كده? We will have thyrotoxic storm, and this is may kill the patient. Very serious complication. You have to cool him because you have high temperature. You have to give him cold saline infusion. You have to give him and these are very difficult to manage. Okay. Okay.
And it's usually occur due to improper preparation for the patient before.
Yes, the patient was not well controlled before surgery. Okay, he was not well controlled. The thyroid function was not well inhibited. Okay, what else?
So we can divide the complication into early and late complications.
Early, intermediate, and late. What is early? Here is thyrotoxic storm. Bleeding is a major problem in thyroid, especially in a thyrotoxic thyroid because the blood supply will be exaggerated. So bleeding is a problem. It may happen during operation. We call it primary. It may happen during stay in the ward in the first day post-operative, 5 hours, 6 hours. You will be called for a patient having subtotal thyroidectomy. He has neck swelling and difficulty in breathing. What is the possibility?
Respiratory distress.
What causes this distress?
Hematoma.
Hematoma. Or if the patient gets distressed immediately after removing, so what are you to do if you have a hematoma, post-thyroidectomy hematoma, and this hematoma is compressing on the trachea? What are you going to do?
Remove the stitches and evacuate the hematoma.
Yes, down to the trachea. مش كده? They remove the stitches, all the layers down to the trachea, and empty the hematoma, put a sterile gauze, and send the patient for the theater. Okay? You do it in the ward before going to the theater. Okay? There are a lot of noise in the background. I don't know why. Can you close your mics, please? Okay, thank you. What other, you are allowed to open your mic just to answer and then you close, okay? What other complication, early complication? If the patient,
Injury to recurrent laryngeal nerve.
Yes, if the patient is operated and after the operation, then this removes the tube, the patient will start to have a problem on breathing, will have respiratory distress or stridor. Then you have to think of what two possibilities immediately after removing the tube. What are they?
If the goiter was big and long-standing, tracheomalacia.
Tracheomalacia. One of the options, usually I haven't seen in my life a tracheomalacia patient. It's very bookish actually. Like, and you are right. If it is a very big, it is not big here, but if it is very big goiter, then you will have tracheomalacia. What else?
Bilateral
partial recurrent laryngeal nerve injury.
Recurrent laryngeal nerve injury. What else?
Laryngeal
most of the early post-op complication here, hematoma causing compression, or laryngeal nerve injury causing distress, or tracheomalacia, or hemorrhage. مش كده hemorrhage in general during an operation. And what are the intermediate complications?
Importantly, hypocalcemia
hypocalcemia.
due to iatrogenic removal of the parathyroid glands.
Yes, and here occurs few days after. مش كده? The patient will have tetany. مش كده? You know, the patient will have tetany. Okay? Carbopedial spasm. مش كده? And so you'll have the chauvinistic sign and the Troisier sign positive. And then the patient will have this low calcium. What are you going to do? If the patient have tetany post-operative في اليوم الثالث ولا الرابع ولا الخامس, what are you going to do?
I give the patient calcium gluconate.
Yeah, very good. Yes. And then how are you going to manage him further? After you prove he has low calcium and he has this parathyroid injury, what are you going to do?
I will continue for calcium for
oral. Yes, calcium in
life.
What else important in the calcium metabolism?
Vitamin D.
Vitamin D.
Vitamin D3, yes. You have to give vitamin D3 and calcium, maybe for life. So what other long-term problem of subtotal or near total actually thyroidectomy?
We can say
Yes.
hypothyroidism.
Hypothyroidism, yes. Hypothyroidism, hypoparathyroidism, and this is a long-term problem of what is the common cause of hypoparathyroidism? Is taking the parathyroid out or another thing?
Injury to the blood.
Cutting the blood supply to the, it is ischemia to the parathyroid rather than removing the parathyroid. Usually surgeons don't remove the parathyroid, but it by the thyroidectomy. You get it? It's the usual condition. Differential diagnosis, investigation, management. Okay, this is a typical long problem. You agree?
Yes.
Then it is very obvious in your mind that the long problem aspect of a clinical problem. He has history, examination, differential diagnosis, investigation, management, and complication of this management and prognosis. مش كده؟ You agree on that?
Yes, Mr.
So, Ahmed.
I have a question: how to manage
Next
the thyroid crisis?
Yes, it usually you have to give him IV cold. You have to call the patient. You have to give him. Actually, it is supportive management rather than anything else. Okay. So manage thyrotoxic crisis. What is best? What is the best?
Prevention.
Prepare the patient.
Not to have a thyrotoxic crisis. Okay. It's better not to have a thyrotoxic crisis. Okay.
Okay.
Better control. How you know the patient is well controlled, thyrotoxic patient, well controlled before embarking doing surgery? Clinically, the
control
the
symptoms.
the disappearance of the symptoms of thyrotoxic symptoms والثاني examination بتكون في شنو؟ أهم examination أهم sign شنو؟
Normal
the pulse. resting pulse. The resting pulse is normal. مش كده؟ العيان قاعد مرتاح وراقد في سرير والبلس بتاعه ماله؟ normal. Then this will give you a clue. Then you will do investigation. You will have T3, which is the most sensitive that the patient is treated. if we have in the 3, T3, T4, or TSH?
Three.
T4, TSH.
TSH.
Yes. If the TSH start to have was very low and then increased, start to increase, then you are confused. Because you get it?
Yes.
Right. Another example of lung problems. A 15-year-old boy was brought to the accident and emergency AE department, complaining of right iliac fossa pain for 6 hours, and he vomited once. He said the pain was initially central. What is the keywords? يلا سريع.
15 year
15 years. ثاني شو؟
vomited once.
يا لا كده انتوا ما تنطوا لي السطور.
Acute 6 hours.
6 hours دي في السطر الأخير. 15 years. 15 years. Boy, ماشي. He's not a girl. To the accident emergency. Emergency. معناها شنو؟
Emergency.
Acute condition.
Right iliac fossa pain. 6 hours. It is not days. It is just hours. And the pain was initially central. What does the patient have? Person. What is it?
Appendicitis.
Acute appendicitis.
Acute appendicitis. Because you don't expect complication because the duration is it's just 6 hours. You don't expect complication.
Yes.
You get it?
Yes.
You don't expect an acute appendicitis to rupture in 6 hours. طيب دارين 3 differential acute appendicitis. In this patient تذكروا ان عمليا عمره 15 سنه. يلا قولوا اي حاجه.
Meikle diverticulitis.
اوكي. انتوا اكثر حاجه نحن يعني نادرا ما تشوفها ها. قولوا حاجات الكومن.
Small bowel obstruction.
right.
inflammatory bowel disease.
small bowel بيجي بالسنترال بين وما بيمشي للرايت الى الفوس.
Uteric colic.
uterine colic.
Yes.
Stone.
Uteric stone.
Perforated peptic ulcer.
اها.
adenitis.
ايوه ميزنتريك ليمفادينايتس مش كده؟ تيرمينال ليمفادينايتس يا اخوان مش كده؟ ممكن تكون واحده من الكومن كوزز اوف ديفرنشال. ثاني
Testicular torsion.
يس ها
Testicular torsion.
هيز ا بوي شنو؟
Testicular torsion.
testicular torsion usually come with hypogastric pain rather than right ileofossa.
Iliopsoas abscess.
ممكن very rare in children لكن okay. ileocecal problems مش كده؟ ileal terminal
obstructed hernia ممكن.
mesenteric. Yeah, yes, it's not usual. Yes, maybe. I think usually come for the 3 important diagnoses. Yes, اللي هي ureteric stone and mesenteric adenitis, acute mesenteric adenitis, ileocecal problems مش كده؟ And this is the most important actually. Okay, what's next? Meikle's diverticulum برضو ممكن. Mention 3 symptoms you will ask for to help diagnose. Okay.
Anorexia.
What are
Anorexia fever.
huh? Yes, anorexia. Usually fever is a late مش كده presentation is a late symptom. لكن loss of appetite مش كده. Usually patients with acute appendicitis they will come ready for surgery. مش كده. They will not take anything. They have anorexia. ثاني it start central colicky مش كده colicky بدأ colicky then it spread it shifted to the right ileofossa. When it shifts to the right ileofossa it disappears from the central مش كده disappearance اللي هي shifting nature of the pain is very important. تاني مع شنو؟
low grade fever انه يكون في low grade.
Yes, ممكن يكون معه low grade fever، ممكن يكون معه fever تاني.
ممكن ال difficulty of walking لما بيحصل له السوى الساين بيكون ليه مشية معينة كده.
irritation. ايوه yes yes you are right. ممكن يكون عنده ديسيوريا مش كده؟ ممكن ديسيوريا اذا كانت الابندكس قاعده وين؟ بلفك مش كده؟ يوريتريك irritation لو كانت الابندكس لامسه اليوريتر مش كده؟ if the appendix is touching
diarrhea
the
برضه.
urethra. Diarrhea if it is a pelvic appendicitis. Yes, you are right. Okay, so a lot of symptoms you can ask for. Next slide. On examination, if the هنا من الديفرنشال عملنا الديفرنشال الاول جبنا السيمبتومز then we come to the examination. The examination the patient was file and not big. What other? Yes. يبقى هون inspection. نبدا من inspection على كده ما تلخبطوا الامور. So خليكم مرتبين. inspection هنلقى شنو؟ The right side of the right iliac fossa moves less مش كده؟ لما ياخذ النفس البيشنت is not moving his right side. ثاني superficial palpation في شنو؟ tenderness وممكن يكون معاه rebound tenderness. ثاني what other is special signs of the appendicitis, acute appendicitis you will do?
coffee guarding.
guarding tenderness وريباوند tenderness. ثاني
Rough sign.
ايوه signs localizing signs اللي هي شنو؟ if the appendix is bull when you press on the left side the patient will feel because this will move the loops of this small bowel and the patient will feel the pain on the right side. بيسموه شنو؟ what we call this?
Rough sign.
ثاني لو كانت قاعدة على البوزيتيف obturator sign or so signs. Are you expected to have all these localizing signs?
No.
Because it depends
The
on
place, location of the tip of the
the
appendix.
place of the site. Yes. Yeah, you are right. It depends on the site of the appendix. So it localizing signs you look for, but you don't expect to find them all positive. Okay. So this the most important is that the right side is not moving with inspection. There is muscle tenderness and guarding, and there is rebound tenderness, and there is localizing sign, Rovsing sign, obturator sign, psoas irritating sign, and all these signs. If the appendicitis is perforated, then you will have signs of peritonitis, مش كده؟ Signs of complication اللي هي بتبقى generalized tenderness and generalized guarding مش كده؟ Okay. Next, the doctor decided to operate. What operation you see? And how are you going to do it? What operation?
Laparoscopy.
Laparoscopic appendectomy for this very young child is good. If the facility is available, if not available, then we'll do appendectomy. Lance, it's not laparotomy, it is lance incision or زمان كانوا بيعملوا gridiron. Like gridiron is obsolete actually. Don't mention it. It's lance or incision اللي هو transverse incision. What is the benefit of laparoscopy over the open lance incision appendectomy?
Short hospital stay.
less admission.
Yes, what is the benefit immediately أول ما تعمل الأوبريشن? It will prove the diagnosis مش كده؟ It will give you a clue. You will have a laparoscopic view of the whole abdomen. You will see that it is not Meckel diverticulum, it is not acute mesenteric adenitis, it is not ureteric مش كده؟ It is not a ureteric problem. It gives you a good view because the lance incision is a small incision that will not allow you to see the whole abdomen. تاني بعد ذاك it is less invasive مش كده and hospital stay and so on and so forth. Okay. يبقى appendectomy is mandatory in this case. If not operated, what investigation the surgeon will need للعيان عمره 15 سنه وده ندخله appendectomy.
abdominal ultrasound.
ده بعد الديسيبل. No, we don't need.
CBC.
CBC and
Yes, all we need is hemoglobin and urine. مش كده؟ He's a very young chap. He's a very young chap. You don't need. Appendicitis is a clinical diagnosis, as you know. If the sonologist say to you, this patient have no appendicitis, what are you going to do?
So
You will be in a trouble. Okay?
Mickel divertical.
the particular.
If the sonologist says to me, this patient has no appendicitis, how can you operate on him? It will be difficult to operate. مش كده؟ So it is a clinical diagnosis يا اخوان عشان نتفق. My dear students, acute appendicitis is a clinical diagnosis. History and examination in the first place. If you are in trouble, then if you are not sure, then you ask for investigation. If you are sure, you don't need to ask for ultrasound or CT or whatsoever. Okay? You get it?
Okay.
You agree? Okay. يبقى two, you just need to do hemoglobin and urine, CBC and urine is enough. Okay?
قال إنه ما appendicitis.
Sure. If you are sure you don't need to go boy, then you can do, he's a boy actually. Then you can do CT or ultrasound or CT. But usually, if the patient have a central abdominal pain that start colicky, that after few hours, 2 hours or 3, that shifted to the right iliac fascia with vomiting once and anorexia and all these symptoms with signs of local rigidity, local tenderness, rigidity, and rebound tenderness. And one of the localizing signs, then there is no need for to do more investigation. You agree? Okay. You are sure that 100% this patient has acute appendicitis. مش كده؟ If you are sure, no need for investigation to prove the diagnosis. Okay? Because the investigation will make troubles of you, will make you troubles. Because they may say, the sonologist may say, no, the appendix is normal. What are you going to do? Okay? So asking for unnecessary investigation usually end by troubles. You get me? But if this patient refused to do surgery or surgery delayed, what are the complications expected? Mention 3.
Perforation.
Rupture appendicitis اللي هي big peritonitis. Rupture appendicitis and peritonitis. Okay. ثاني. If this rupture is walled off by omentum, what will happen to the patient? Well, patient will have
Appendicular mass.
Okay. If this bacteria overgrow in this appendicular mass in its exudate,
Appendicular abscess.
abscess. يبقى 3 واضحات. اي زول هيكتب غير الثلاثه. او walled off perforation بقى ماس او abscess. اي زول هيكتب غير الثلاثه دي اديني نمره كيف يعني. You get me? لكن this is not a complication, huh? For appendectomy. سؤال واضح سهل. What is appendectomy? Is it what type of wound is this? احنا اتكلمنا الدور اللي فات عن الwounds. What type of wound is this?
Clean.
ها؟ ارجع ورا شويه. ها؟
Clean contaminated.
Contaminated, yes. Clean contaminated او لو حصل فيها ربشر. لو localized rupture بتبقى شويه. ادينا السؤال الاخير. complications. Okay. ممكن يحصل فيها infection. What is the organism؟
E. coli.
يعني usually ثاني معاه برضه microbes مش كده؟ usually microbes. So we'll give metronidazole مش كده؟ Yes. So you have to give any following the site has to contain antibiotic against anaerobes. So we'll give metronidazole. Okay. 2 post-operative complications اتكلمنا عنهم افتكر قلنا infection وثاني infection wound infection ممكن يحصل bleeding. يحصل bleeding من وين؟ Yes. السليب دي يا تو ارتري السليب ده. appendicular artery مش كده؟ if you don't like it appendicular artery وهو برانش من وين؟ من الايلوسيكال artery مش كده؟ So it may happen bleeding from the appendicular artery, so it has to be ligated مش كده؟ بعدين ممكن يحصل لك شنو؟ leakage من if you don't ligate the stump of the appendicitis well, then it will have leak مش كده؟ leak من السيكم مش كده؟ Okay, appendix is opening in the cecum. You get it? This is a complication of appendicitis injury to the nearby structures, ileum, cecum. Okay. Okay. Then this will emphasize that the importance of the long problem that you have to cover all the aspects of the clinical problem of the patient, starting from the history, examination, differential diagnosis, investigation, management, complication, and prognosis. Okay, you get it? In contradistinction, if we move to the short problem will concentrate in 1 or 2 or 3 aspects of the aspects of the long problem. معلش aspects حتى لو بيناتهم مسافات. Okay, what are they؟ يلا قول لنا الاسبكتس. الكلام ده ليكم انتم. دول يجاوب سريع. What are these aspects?
Diagnosis, management, history examination and prognosis.
Okay. يبقى this is how this aspect actually يبقى واحد منهم واحد ولا 2 ممكن يكون شنو ممكن يكون symptoms ممكن يكون معاه investigation ممكن يكون معاه complication مش كده ممكن يكون science معاه investigation معاه complication دي شغل the aspects of the problem كلها واحنا بنختار الاسبكت دي because they are important. ندي example للحكايه دي يا احمد next time. Yes, a 26 years old male admitted to emergency room following a road traffic accident. He was dyspneic with respiratory rate 60 minutes per 60 times per minute. Blood pressure 90/40. Breath sounds were markedly diminished on the right side with hyper-resonant percussion. What are the keywords? نفس الحكاية. The same approach. What are the keywords? Yes.
road traffic accident.
What are the keywords? The keywords ما متطور يا أخي. السطر الأول ده
26 years.
ايوه هو يعني مش كده admitted to emergency room road traffic accident وكان جابوا شنو ديزني respiratory rate كان 60 دي very ديزني وبلاد بريشر 90/40 كمان هايبوتنسيف مش كده والبريس sounds في الرايت سايد مالها
pneumothorax.
نيموثوركس تنشن نيموثوركس
يعني تنشن كولابس مش كده maybe tension مش كده maybe not okay لكن you have to talk about pneumothorax maybe tension. Next please. What is the most likely diagnosis?
Tension pneumothorax.
Tension, because the patient hypotensive. مش كده؟ مش كده، لأنه لو في bleeding كان الجست بيجي شنو؟ كان بيجي ضل مبركش، ما بيجي hyper resonant. مش كده؟ And this hypotension is due to compression on the heart and the major vessels. مش كده؟ It is most likely it's a tension pneumothorax. More physical signs, 3 more physical signs. تراكية تبدو من ابدا بالانسبكشن. تراكية، ما انتم فاهمين الريسبيراتوري سيستم كيف كان بيكزامن، بيبدوا بشنو؟
من الاول انسبكشن اوف ذا تشيست الموفمنت بتاع التشيست، لو يونيلاترال بايلاترال.
ايوه موفمنت، ايوه diminished في الرايت سايد وبتكون واضحه، وبالرايت سايد is bulging والتراكيه is pushed to the other side. مش كده؟ وثاني الهارت ماله، البلس الابيكس بيت is pushed to the other side. مش كده؟ مش كده؟ اوكي؟ الثاني طيب ده تقول شنو؟ يس
decrease في التكتايل vocal.
ها برضه اللي هو بتكون من اوكي. يبقى عندكم a lot of signs you can talk about because this is a pneumothorax pushing the heart, pushing the trachea, and explain 2 life-saving steps. يبقى this is a life-saving problem. يبقى دي شنو؟ What is the diagnosis now?
immediate
ترجعوا تصلحوا الدياجنوز بتاعكم
chest
ده.
drain.
يبقى دي tension pneumothorax. مش كده تصلحوا الدياجنوز، ما تجاوبوا. لازم تقروا الاسئله كلها عشان تجاوب. tension pneumothorax تعمل كيف تعمل؟ بدل نعمل عندنا 2 steps اللي هو تخط نيدل وين؟ وايد بور كانيولا وين؟
second
intercostal. When you put like the يكون عندك كرة وهينزل هيكون في صوت. أول ما الصوت يجي معناها شنو؟ معناها الهواء قل، ما في يعني، مش كده؟ So you remove the needle after the gush of the complete gush of air. طلع الاير جا gushing، طلع لغايه ما وقف، بعدها خلاص you take the needle out, you ask the patient to do a chest X-ray, and then you what's next after the chest X-ray proves that he has pneumothorax?
chest tube. chest tube.
في الوين؟ where to put the chest tube?
Fifth intercostal space.
Yes.
Mid axillary
mid axillary line, anterior axillary line actually, or mid axillary line
with under seal مش عارف.
and water seal. chest tube and يبقى these are 2 life saving steps in the management of this patient. ثاني next ولا انتهت كده؟ ماشي ثاني سؤال؟ اوكي. يبقى ارجع ورا. يبقى اذا this problem جاتنا في شنو؟ في how to save the life of the patient. يبقى شايفين المانجمنت، الامرجنسي مانجمنت بس كان مركز. ارجع السؤال اللي قبله، السلايد اللي قبله لو سمحت. يعني هو كان مركز على الحاجات اللايف سيفنج. هنا الهدف بتاع هنا ده انك انت مطمئن الى انه الطالب when this student graduates he knows how to deal with tension pneumothorax. Okay? This is the aim. يبقى short problem دائما الايم بتاعه محدود. The objective of this problem is very limited. Okay? You get it? It's not like the long where the aim is bigger. هناخد another example. Next step, next slide. A 60-year-old gentleman presented with painful right inguinal swelling, which was associated with vomiting. He gave history of disappearance of this swelling when he lay down. He gave a past history that in the history this swelling used to disappear. The treating doctor examined his chest, abdomen, genitalia, and lower limbs. The only positive finding was a intense tender right inguinal swelling. طيب, what are the keywords here?
60-year male.
Male, yes.
Painful inguinal swelling.
Painful right inguinal swelling. Yes. Associated now.
Vomiting.
History of disappearance. كان زمان قبل فترة كان بيطلع when he lie down. يبقى what is the diagnosis?
Usable.
Strangulated right inguinal hernia.
inguinal hernia. لكن حسي مالها
strangulated.
strangulated painful. يبقى البينفول ما بيجي الا يكون في strangulated مش كده؟ وماشي معانا في الاكزامينشن لقى شنو تو بروف انه دي strangulated في شنو؟ tense tender right inguinal swelling. يبقى خد تحت من خطوط حمر tense tender right inguinal swelling يبقى الدايجنوز شنو؟ Yes, go next slide. What is this swelling? Swelling ده شنو؟
Strangulated.
strangulated right
Inguinal hernia. Right
Yeah.
inguinal hernia.
مش كده؟ This is strangulated right inguinal hernia most likely. مش كده؟ ليه؟ لأنه فيها painful وفي vomiting وكده. اوكي.
طيب
أنا ماشي.
الاوبستراكتد بتختلف عنها ايه في الهيستوري؟
البين التندرنس there is no tenderness just obstruction simple obstruction.
اوكي.
مش بيكون فيها ساينس obstruction.
ايوه just signs اللي هي vomiting وكده and there is no ما بتكون tender it will not be tender once it is tender معناها حصل فيها strangulation you get it. يبقى الكومبليكيشن usually complication of this type of swellings. Yes, you are right. الزول كتب كلام جميل قال right. I agree with him. He said right. Right-sided strangulated inguinal hernia. Excellent. This is I don't know his name, but he's excellent. Okay. What are the complications of any hernia?
ischemia.
يعني
Perforation.
نبدأ بالتدريج شوية. يبقى يحصل فيها تبقى شنو؟ أول حاجة تكون reducible, then irreducibility, then obstruction, then strangulation, then carceration, then ischemia, then perforation. مش كده؟ دي كلها complication. Okay? You get it? يبقى تستart irreducible, obstructed, strangulated. بعد ذاك ممكن يحصل فيها ischemia, perforation. This كلها complication of this hernia. Next, what is the management in the casualty? يبقى العيان ده جاك strangulated inguinal hernia. What is the management? المانجمنت اول حاجه you have to start with resuscitation like because strangulation ممكن يكون معاه sepsis مش كده ممكن العيان يكون شوك او يكون he needs resuscitation ABCs airway breathing circulation giving him IV fluid antibiotic by mouth you prepare the patient for antibiotic, IV fluid, electrolyte disturbance correction, and if his hemoglobin is low, you have to talk about all these resuscitation, airway, breathing, circulation. You have to do investigation. You have to insert an NG tube, a Foley catheter, IV fluid, antibiotic, electrolyte disturbance correction, hemoglobin correction, and then for emergency laboratory. مش كده؟ You may find في واحدة تليفونها ما هنا صوتها دايما بيكركر. اوكي next احمد. يبقى هنا احنا we are talking about مش كده؟ about نرجع تاني للبروبلم دي نرجع خطوتين لورا احمد. yes we are talking about تاني ورا تاني. just we are talking about one of the emergencies expected top emergencies. Strangulated inguinal hernia. Strangulated hernia is a common problem you can see. مش كده؟ Complicated hernia you can see the casualties. It's not a rare condition. It's not that uncommon. Okay. So this we're talking about how to manage in the emergency room of a patient with strangulated hernia. So the objective of short problem usually is very limited. Is very short. Okay. Next slide. Any questions so far? Yes? Any question?
No.
Any questions so far? So as in conclusion, to solve any surgical problem in a written exam, you have to discover the keywords. You have to enumerate, you have to pick up, you have to know what keywords. The keywords in any problem is given to make you a clue to what is the problem. Then you have to put up differential diagnosis. From the differential, see the most likely diagnosis, and then the expected symptoms and signs, and the important investigation, and how to manage, and what are the expected complications and the expected prognosis. Okay. Okay, next slide. Long problems will address all this, while short problems will address some of them, not all. It is very difficult for a short problem to discover all these aspects, but the long problem definitely will do. Okay, so in the exam we are insisting in putting long problems with short structure because to cover all these parameters. Next slide. And see how the examiners are very putting high tension on the performance of the student, because they are going to graduate her as a profession, as a doctor. Thank you. You'll see Mr. Muhammad Tom. Muhammad Al-Taib, you know him, Muhammad Tom from Kosti, Nile White University. He's putting a lot of concentration on the medical student to assess her performance. So, six to eight short problems, usually six. Okay, any questions so far?
Very, very useful and beneficial session. Be honest.
Thank you. Thank you. The one best answer. You have to give me time, please. It needs to have
all time.
Best answer questions is a very complex thing. It needs time to be prepared. Okay, in this week. Okay. Is the time is okay with everybody? Any problems? Any way we do things?